Thank you guys for having me. It's such a pleasure to be here. To bring up the slides. I've been part of this group for 6 years now, I believe, and it's been really fun to see the evolution and meet so many of the families, and I look forward to meeting more of you guys today. This is going to be a little bit of an overview of the clinical presentations of SCN2A across the spectrum. I'm not going to dive deep into data because you're going to see that in the rest of the slides today, but I'm happy to answer questions. And we do have a cohort at Boston Children's Hospital who we've been following over time. Are going to be doing some more genotype phenotype analysis, and we're collaborating with some of the groups here doing some of the electrophysiology. So I do serve on the medical advisory board, as you saw, and we have some collaborations, as I mentioned, especially with Al George and Ted Cummins, and my fellow Isabel Haviland. Say hi to her if you see her today. She's doing some great work and starting a project looking at genotype phenotype correlations for our cohort as well. I'm going to, like I said, talk about the broader phenotypes and touch on aspects of epilepsy, movement disorders, tone, autonomic symptoms, autism spectrum disorder, and intellectual disability in broad strokes, as well as the impacts of each of these on treatment approach as we know it today. Helen is one of my little buddies, as you just heard, so feel free to say hi to him. He's a cutie. It's not the end of the world if they have my notes. So while she works on that, I'll just talk a little bit. So we sort of divide we call it phenotypes, but that basically means a clinical presentation of how the kids present into a few different groups. And some of them are based on age of seizure onset, which has been a differentiating feature. And then there are some children who don't have seizures and have more predominant autism and intellectual disability presentation with or without seizures that may present later. And you'll hear a lot of work today about how the different clinical presentations and the genetic variants relate to how the channel is actually affected by those genetic variants. We think about gain of function, especially with early presentations, versus loss of function. That tends to be more intellectual autism disability with or without seizures. And there's a group of mixed function, which is complex, but can affect the main electrical activity is actually reduced, but there can be like leakiness to a current, persistent current, resurgent currents, and we can see some intermittent later onset, more severe epilepsy and developmental disorders in that setting as well. So these are kind of the broad groups. I'll talk about self-limited epilepsies, early on infantile developmental and epileptic encephalopathy, which is a term that indicates there's developmental and cognitive impairments that are and behavioral issues that are related both to the abnormal electrical activity as well as to the underlying disorder, in this case, the SCN2A variant. The later onset developmental and epileptic encephalopathies, DEE is the term we're going to use for that. There are movement disorders within those, and then there's a defined intermittent ataxia, which has been well defined, and that can overlap, especially with the early onset epilepsies, and in particular the milder spectrum. These are the figures. There are breakdowns from a couple of manuscripts in dividing those groups in various different ways. The one with the more aspects on the right there, the Zhang, divides it by specific epilepsy syndrome. And an epilepsy syndrome is essentially a description of the seizure types, the age of onset, and the EEG patterns that we see. So that's what we mean when we say an epilepsy syndrome. Whereas the Wolf paper in 2017 did the broader categories similar to what I'm describing here. And we'll break those down. Oh, no, I'm not moving, Christina. So this is just one other look at kind of the bigger picture of those subcategories, looking at it by age of onset of the seizures on the x-axis and development on the y-axis, going from normal to severe developmental delay and intellectual disability. So the early onset normal, which has a broader range, is the self-limited epilepsies, and then the more severe DEs are towards the bottom left, and then the loss of function groups tends to be more towards the right, with the intellectual disability, autism with or without epilepsy. Dr. Sanders has an updated version of this that you showed yesterday that shows a little bit more. This shows the spectrum of the gain of function towards the red side, the loss of function towards the blue side, normal in between. But there is actually this other category of the mixed effect on the channel, which can cause a developmental and epileptic encephalopathy with a little later onset after 3 months of age. So that's an important group to kind of include in here as well. So with the self-limited epilepsies, they can run in families. So I showed a pedigree there. The individuals in black are affected. They have infantile seizures, and the individuals in white are unaffected. Plus means that they carry the variant in SCN2A, and minus means they don't. If there's no plus or minus, then they weren't tested. So you can see that it's tracking in families in a dominant manner, about a 50% chance of inheriting the variant. And if you have the variant, you tend to be affected. This can be familial or it can be sporadic. A new variant can pop up and cause the spectrum of disease. The range of age of onset is pretty broad, from 2 days to 23 months. They're often very early onset, but not necessarily. Seizures are typically focal with stiffening, what we call tonic, or jerking, we call clonic activity. Focal meaning they come from one part of the brain and not a deeper focus that spreads everywhere immediately. The seizure is typically resolved by 12 months with rare recurrence later in life. Developmental and cognitive outcomes are typically normal. And in some individuals, you can see a later onset movement disorder, usually after a year of life, episodic ataxia in particular. It's a balance coordination problem that can come in waves, and we'll talk a little bit more about that. This particular epilepsy syndrome is often in other genetic causes associated with something called paroxysmal dyskinesias, which is a hyperkinetic movement disorder with irregular excess movements, but we don't actually have that particularly associated with SCN2A. So this is a case example, but I actually put self-limited question because it shows you that it's not always black and white. And this one is maybe self-limited, but maybe actually has some ongoing epilepsy. Boy born at 34 weeks by twin pregnancy, no perinatal complications, lived a little bit preterm. Did okay until 3 months corrected gestation age, so 4.5 months, but corrected to 3 months, had onset of focal motor seizures. He's had completely normal developmental and cognitive outcomes. Seizures were controlled and he came off of medication, but starting about 2 years, had some paroxysmal episodes. Not very often, so they haven't been captured on EEG, but he intermittently will feel shaky inside, run to his parents. Can't outwardly see anything, but afterwards he has a little slurred speech and shuffling gait, not quite himself. So we suspect they may be focal seizures, but he has a 24-hour HE that was completely normal. So a little bit of an unknown. So moving on to early infantile developmental and epileptic encephalopathies, these are the seizure onset less than 3 months. They're often refractory, meaning not responding well to our medications, associated with global developmental delay, intellectual disability in the majority. EEGs range from burst suppression, which is one of the more severe neonatal EEG patterns, to a range of abnormal patterns. They are commonly associated with movement disorders. So in particular, dystonia, which is stiffening. So writer's cramp is a mild form of dystonia, but these kids can have a segmental, multiple joints affected, or whole body dystonia that can be really problematic for quality of life. Choreoathetosis is another movement disorder that can be kind of a subtle wiggling. Distally is the chorea. The athetosis is a little more proximal truncal wiggling movement. And that also can be really affecting quality of life and can burn a lot of calories. So that can be a problematic movement disorder, and others that can be milder. And then dyskinesias are a bit more nonspecific excess hyperkinetic movement. So all those can be seen in the spectrum of disorders, not usually as often the episodic ataxia. Muscle tone can be high or low. And that can be problematic. Yeah, these kids, we often, and many of you probably follow with orthopedists and rehab doctors, physiatry for complications of tone, like impacts on the spine or the hips. It's something we suggest if there's significant tone abnormalities, as well as help with bracing and that sort of thing. Cortical visual impairment is a common problem that you're going to hear a lot about at the conference too. And then autonomic symptoms, so temperature instability, tachycardia. This can affect the GI system. Raid McSweeney from our group is going to come talk about GI effects tomorrow. So stay tuned for her talk. Sleep can be impacted, so the autonomic system is really important. Less well described in the literature, but really important and noticed by all of you. So early infantile DEEs with burst suppression, that particular EEG pattern that I mentioned, these present with epileptic spasms, which are brief stiffening and relaxing in clusters, tonic seizures or myoclonic seizures that are like lightning bolt jerk fast. They have this severe abnormal pattern that I'm going to show you on EEG. It is one of many genetic causes of this syndrome, of which there are subsets. Ohtahara syndrome, early myoclonic encephalopathy are terms that you may have heard that fall in this subset. So there's some literature suggests that sodium channel acting medications can be beneficial. Phenytoin in particular, as you just heard in Colin's story, that these kids often require high doses of phenytoin, and it has this funny chemistry that when you get to those high doses, you near the zero order metabolism, and then you can skyrocket. So you're at this very teetering balance between, I go a little higher and I get toxic, and I go a little lower and the kiddo goes into big seizures and status epilepticus. So it's a challenging balance to reach. And sometimes the other sodium channel blockers can be helpful, but not always. There are some risks for shortened lifespan, such as aspiration or status epilepticus or sudden unexpected death in epilepsy as well. This is the pattern of burst suppression that I mentioned there. Each of the letters on the left are an electrode. If your family member has had an EEG, and each channel there with the squiggly lines is one electrode comparing to a neighboring electrode. And in this pattern, you have these high bursts. There. Does this work? Yes. You have these high amplitude bursts of activity and then these periods of suppression in between. So these epilepsy syndromes, I just wanted to mention too, are to some degree age dependent. So many of these kids with severe gain of function DEs present in the first few days of life. And in that neonatal period, the burst suppression or Ohtahara syndrome is one of those syndromes that tends to occur in that age range. Those kids can go on and evolve to other epilepsy syndromes that tend to happen more at different ages, like West syndrome, or now we call it early infantile epileptic spasm syndrome is a little bit broader term. That's the updated term. West syndrome is a triad of epileptic spasms, hypsarrhythmia, specific EEG pattern, and developmental regression. And then you can go on to something called Lennox-Gastaut syndrome, which is a syndrome with multiple seizure types and a particular EEG pattern of diffuse slow spike in waves with or without paroxysmal fast activity as well. So there's a sort of an age dependence on what the brain does, regardless of the underlying cause. And kids who present later might present with West syndrome or infantile epileptic spasm syndrome, for example. So the other common specific syndrome within this early infantile DEE group is epilepsy of infancy with migrating focal seizures. The age of onset is fairly young. For the syndrome overall, it's less than 6 months. For SCN2A, the cases reported have been mostly under 8 weeks and usually very early. It's an interesting syndrome with focal seizures that sort of ping pong between the hemispheres. One seizure is evolving and then it kind of pops to the other hemisphere and new seizures evolve and they kind of ping pong around. They can be prolonged and sometimes evolve to status epilepticus, and they're typically associated with pretty severe developmental outcomes. Again, like with Ohtahara syndrome, this is one of many genetic causes. So SCN2A is here amongst other genetic causes, KCNT1 being the most common, and Ohtahara KCNQ2 is sort of the cousin most common, but SCN2A is prominent in both of those. So an example here, you actually heard Colin's story, which is a nice example of this early onset DEE, but he certainly has challenges ongoing, but his seizures are mostly controlled now on a single medication, which is great. And he had multiple years of seizure freedom, which is not always the case. And we don't have great predictors of who is going to have ongoing difficult to control seizures versus not. And I have lots of kids who have ongoing tough to control seizures as well. So here's just another example of a term baby girl, no complications, had seizure onset at day of life 1 with focal tonic seizures, multiple per day, was on multiple medications with sort of partial response to sodium channel blocking medications. In early childhood, she's actually reasonably well controlled now on a combination of lacosamide and lamotrigine, particularly sensitive to missing doses of lacosamide. We think that's been the main one helping her, interestingly, similar to Colin. I don't know, not a lot of literature to support that specifically, but it's interesting. She also initially had a burst suppression pattern on her EEG, has evolved to other patterns over time, severe global delays, swallowing difficulties, and poor weight gain. So the later onset DEEs with seizure onset greater than 3 months, there's several defined syndromes. I've talked about a couple of these: infantile epileptic spasm syndrome I mentioned, Lennox-Gastaut syndrome I mentioned, epilepsy with myoclonic atonic seizures, or sort of a lightning bolt jerk and then a drop. And epileptic encephalopathy with spike wave activation in sleep, or you may have heard of epileptic status epilepticus of sleep, or these patterns where you get continuous spiking in sleep and you can see setbacks in cognition and language and development in that setting as well. So we've seen that occasionally. Again, movement disorders are common in this subset, like the early onset DE group, choreoathetosis and dyskinesias. Autism spectrum disorder and intellectual disability overlap, as with the early DEEs. Muscle tone abnormalities similarly can be low tone or high tone. And with regards to treatment of epilepsy in this group, they're less likely to respond to sodium channel blockers. I'd advise some caution with the later onset epilepsy because they tend to have more of a mixed function, and sometimes kids can get worse and may do better on other mechanisms, but we don't know for sure. So just an example of a kiddo who falls in this group: normal birth and development, had onset of infantile epileptic spasm syndrome at 10 months of age, not controlled on the initial treatment, but was eventually controlled and then recurred with spasms again at 3 years of age. She had developmental regression with the onset of those initial spasms and never fully recovered those initial skills. And later has more focal to bilateral tonic-clonic seizures or focal seizures, and has chorea as a movement disorder that isn't requiring treatment, but is fairly common. So episodic ataxia, a non-epilepsy syndrome or a movement disorder, but again, it can overlap with individuals who have early onset seizures, and this can happen anytime from around a year of age into adulthood. It's highly variable with regards to duration and frequency. The episodes can last anywhere from minutes to weeks, and again, the frequency is highly variable as well. There can be some triggers such as head injury, sleep deprivation, alcohol, noise, menstrual cycles, variety of triggers similar to seizure triggers. And it's not just imbalance in coordination. You can also see some slurred speech, tremors, vomiting, pain. Cognition is often normal in this group, which is why it tends to be more that self-limited epilepsy spectrum, but not always. And there are some with cognitive impairment. And treatment response is not great for the ataxia itself. Then I mentioned this subset of kids who have more predominant autism and intellectual disability, with epilepsy being variable, and the severity of that epilepsy, if it happens, is highly variable as well. But many of the kids actually can be controlled on one medication or even come off of medications, whereas others have a tougher to control epilepsy. So there's ongoing research, and you're going to hear some great talks today or tomorrow. Dr. Berg and Dr. Ludwig have some really great data on the developmental outcomes of kids with SCN2A related disorders. So stay tuned. As far as neuroimaging, the brain structure is usually normal. We can see some atrophy or volume loss, especially in the kids with the more severe epilepsy, but broadly, there are some rare case reports of malformations that indicates the channel having some role in brain development in utero, polymicrogyria in particular, and some case reports of absence of the corpus callosum, which I've actually never seen myself. So that's a structure that connects the left and right hemispheres of the brain. The other aspect that I didn't talk as much about, but is out there in the literature a little bit, is as our individuals get into adulthood, there are some reports of schizophrenia or psychosis, and that's something that we'll need to follow in more detail. I'm a pediatric neurologist. It's not my area of expertise, but I hope there'll be more information in that long term as far as what are the risks and how common that is. So this is a little bit broader view, but to sort of celebrate what the SCN2A community has been able to do, and that you'll hear more about in the next 2 days too. Precision Medicine 2023, this was a review. And just to highlight, as far as gene discovery and diagnosis, we're making significant progress. There's more and more review here every year. I want to credit Lacey Smith, who published some guidelines for genetic testing in epilepsy, suggesting next generation sequencing on anybody with unexplained epilepsy that hopefully is helping us get more diagnoses. In the autism world, there's more exome sequencing happening as well. So I think that's helping. As far as natural history, you're going to hear about the Clinical Trial Readiness Project, the Instones Project, several projects that are really gathering great data, and hopefully we can continue to advance that over time so we really know what outcomes we're looking at when the clinical trials are ongoing and finished, which they're starting to. You're going to hear about preclinical models, and drug discovery. We're working towards more gene-based and RNA-based therapies in addition to small molecules that are heading towards our community. And we're hopeful that those are going to be able to make a difference. And we need to know what we're treating when we do that. So building the community, establishing databases that can link to each other and really understand, and probably getting some more in-person data as well is going to be critical. And then work towards clinical trials, organized clinical trials. And one is mentioned there, which is something that you'll hear more about from Wendy Chung, our new Chief of Pediatrics at Boston Children's Hospital, at the conference as well, and an area of interest to me also, in addition to the clinical trials. And we'll have some great discussions about that. So I don't want to take too much time because we got a little bit delayed. Just quick note on clinical research and trial involvement. You guys are mostly involved. It sounds like you're doing a great job, but really helpful to have observational and natural history studies to, again, understand where we are so that we have a treatment we know we're making progress or not. If you're thinking about experimental therapies, there's two big categories: small molecules, a drug that you take by mouth or by gastrostomy tube, versus gene or RNA-based that might be IV-based. It might be an injection into the spinal fluid. It might actually be infused into the brain, depending on what approach it is. And each of those are going to be, they may be specific to the type of variant in SCN2A. It's not going to be sort of SCN2A treatment. So they're all going to have specific criteria that they apply to for good reason. They may be based on clinical presentation. There may also be experimental therapies that are available based on epilepsy syndromes and not necessarily specific to SCN2A that might be looking into. So if your treatment paradigm is not working, it's something you can consider talking to your team about, and important to look at risk-benefit assessment and logistics for each particular study and or trial as it relates to the goals for your family and for the community. Happy to answer more questions. Thank you for having me.
Thank you ever so much. We're now going to move on to our next speaker, which is Stacey Cohen from Children's Hospital of Pennsylvania, on understanding your SCN2A variant. Welcome to the stage. Thank you.
Okay, good morning, everyone. Thank you so much to the Foundation for inviting me to speak. I'm Stacey. I'm a genetic counselor at the Children's Hospital of Philadelphia. And today I wanted to talk to you about information that you need to know in order to understand the genetic background information and how to read and understand your child's genetic testing report. So I want to start out just by talking about some fundamental concepts in genetics, how this is applied in the SCN2A gene specifically, and then putting this all together to what you need to know about your child's variant. So starting out with a genetics background. When we think about our genetics, I like to think of them like an instruction manual that our body has to read in order to tell our body how to grow and how to develop. So this is all in our genetic code. And our genetic code is packaged into what we call chromosomes. And these chromosomes, which you can see if we kind of neatly align them and put them together, are these lines on the slide. And these chromosomes, we have 46 in total, 23 pairs with one from each pair coming from each parent. And we know that the SCN2A gene specifically is on chromosome 2. And again, there's 2 copies of this gene in each individual, one coming from mom and one coming from dad. So all of the things that I just talked about with chromosomes and genes, these are the building blocks, the foundations of genetics that have been known for many, many years. But in the scheme of our knowledge of genetics, epilepsy genetics and the genetics of neurodevelopmental disorders is really a newer field within the field of genetics. So, if you have a child with epilepsy or autism and you walked into a genetics clinic maybe 20 years ago, what we would have told you is genetic testing is probably not going to find an answer for you because it's very complicated. It's research. It's not really something that we do in clinic. But now, with advances in technology and knowledge, we actually do know that we have a very good chance of finding the cause through genetics. Typically, these are changes that are new in a child or de novo. And it's becoming more and more the clinical standard. And I think that this is really important to emphasize, this history of the field, because I think it really highlights the advancements that all the scientists are going to talk to you about today. We've really come a long way, and there's a lot farther to go. But I think this is a kind of a good foundation to frame everything. So when we actually do genetic testing in this patient population, in patients with severe epilepsies or epileptic encephalopathies, and this is a study back in 2016, which did this, SCN2A is really one of the most common genes that we find. And again, I really want to highlight this because I'm sure, going through your diagnostic journeys, depending on where you had your genetic testing done and what expertise was there, many times families will encounter providers who've never heard of SCN2A before, and they just didn't have a lot of information about it. But as genetic testing is becoming more and more common, it's important to emphasize again that SCN2A is one of the most common things that we find when we do genetic testing in this population. So awareness is extremely important. So all of this talk about SCN2A, what actually is it? SCN2A is a gene which encodes a protein, a voltage-gated sodium channel. And SCN2A is one of the voltage-gated sodium channels in the brain, but there are others. And it's really important in early development as well as throughout development, but in early development is expressed in this segment of the nerve cells called the axon initial segment, which is a really critical piece of the nerve cell for its function. And there are other genes that are really important at the same spot, like SCN2A and KCNQ2 that are also implicated in neurodevelopmental disorders. So now getting into more specifics about the different types of changes that are found in the SCN2A gene called genetic variants. So I think we can all appreciate that SCN2A is not one condition, even though it's all caused by the same gene. You'll meet many different families at this conference, and just throughout being in the community, you'll see each child has a unique presentation. Each child has a different set of symptoms. And the reason, or part of the reason for this, has to do with a particular spot in the gene where their change is present. So what this slide is showing is if we took a picture of the SCN2A protein and we flattened it out, this is what it would look like. And there are arrows that kind of show different spots throughout the protein where changes have been reported before. And in the bottom half of the slide, you can see different what we call phenotypic categories, or different groups of types of presentations that we can see associated with variants in the SCN2A gene. And there you can see there are changes throughout the entire protein. There are some changes that are more common, some changes that are reported only in a single individual. And it's important, again, to know which particular change a given individual has, because this plays a role in what we think about the symptoms that they may be at risk for and their treatment and management. So these SCN2A variants or changes, this language that I keep throwing around, a variant is like a change in a gene. So it's like you have a word and you've swapped out a letter, for example. And it's important to say most genetic variants in our bodies in general are not harmful. They have to do with our particular family's background, where we're from, but it's not necessarily, most changes are not actually related to our health in a measurable way. So when you do genetic testing, when you do that cheek swab or blood draw and send it off to the lab, their job is to parse through all of the genetic changes and identify changes which are actually harmful. Harmful in the sense that they disrupt or change that gene's protein product. Because we know that when SCN2A protein is missing or functions in an abnormal way, obviously this changes brain functioning. So you're going to hear the terms gain and loss of function a lot throughout the conference and through talking with families. I'm going to give a very basic introduction to these concepts, and some talks later are going to explain all of the nuances that kind of go into this. But what I've shown here on this slide is a very basic illustration of what a sodium channel is. So we have our sodium channel, and sodium is passing through the channel. And there are two copies here, again, to illustrate that there are two copies of the SCN2A gene. So when we say loss of function, what we mean is one of these copies is not able to provide this typical functioning. Either the protein is not made at all, or the protein that is made is not able to allow sodium to pass through. And when we say gain of function, there's really lots of different components that can underlie this. What I have here on the slide is just one example. Let's say there's too much sodium that's allowed to pass through. And this is what's actually underlying the change in brain function. So how do you know whether your child's variant is gain of function, is loss of function, is somewhere in the middle along the spectrum? One of the really important ways to answer this question is actually being able to dig into the particular variant that your child has. So what we have here on the slide at the top is our DNA, again, our genetic code. And this is a 4-letter code. So you'll see A's and T's and G's and C's. And this is the building blocks of our genetic code. And our genetic code is read in groups of 3 letters at a time. So when our body is reading this genetic code, it's reading through these letters 3 at a time. And then it's using this in order to build the SCN2A protein. So each 3-letter code corresponds to a building block of a given, of a protein called an amino acid. And so when we talk about how to name a given genetic change, there are different ways that we can do this. And this is what's going to be on your child's genetic testing report. So firstly, on the left, you can see we have what we call the genomic position, which starts with a G dot. This is not super commonly noted on the genetic testing report, but it is one nomenclature. So I wanted to at least bring a little bit of awareness to it. But the most common ways that genetic changes are named are with what we call a C dot and a P dot, so the middle and right-hand side. And they're each referring to different aspects of the genetic change. So the C dot is referring to the change on the DNA itself. So the way that we read this, for example, the example on the slide, if we look at the 2,558 position, typically there's a G in the code there. And then that greater than sign means is changed to. So at this position, typically there's a G, and this is exchanged for an A. Then when the body goes to use this genetic code to build the SCN2A protein, this is when we get to the P dot. So the P dot is referencing what change in the protein is caused by the change in the DNA. So the way that you read this is that at the amino acid position 853, typically there's an ARG or an arginine. And instead, because of this change in the DNA, there's a glutamine instead, or GLN. So there are different classes or subtypes of genetic changes. And by far the most common type is something called a missense variant. And a missense variant means that one spot in the genetic code, one of those A, T, G, or C's is swapped for one of the other letters in the 4-letter code. And so when the body reads this, it exchanges the amino acid that's typically there for a different one. And again, this is how this is typically noted on a genetic testing report. Then we have what we call nonsense variants. Again, this means that there's a swap of a single spot in the DNA code, but rather than putting in a different amino acid or a different protein building block, it's actually putting in a stop. And so it's kind of like if you have a sentence and you put a period in that sentence too early, you're cutting off that second half of what you were trying to say, you're losing the meaning of what you're trying to say, and that sentence no longer has the meaning that it's supposed to have. So that's a nonsense variant. And the way that you can tell the difference between these different types of variants is usually within the P dot or the protein annotation. So typically, if your child has a nonsense variant, that's noted with an asterisk at the end or with an X. Those are kind of the most common notations for a nonsense variant. We also have what we call frame shift variants. So we talked earlier a little bit about how our body reads the genetic code in batches of 3 letters at a time. So if you add in a letter somewhere in that code, it may shift the set of 3 letters that it's trying to read. So what this ultimately causes is incorrect amino acids being inserted, and eventually it leads to a premature stop. And so the way that this is typically annotated on a genetic testing report is again in the P dot, and it will say at the end, FS, either an asterisk or an X, and then a number. And that number means that frame shift is by 11 amino acids, and then a premature stop is inserted. So you're still cutting the protein off too early, but in addition to that, you're adding incorrect amino acids prior to that premature stop. We also have what we call splice site variants. And this has to do with the way that our body actually processes the DNA. So there are different segments of our DNA called exons and introns. And one of the things that our body has to do is remove these introns when it goes to actually build the protein. So if there's a genetic change which interferes with the body's ability to recognize where an intron stops and starts, that can disrupt this process. So this is something that you would typically see rather than in the P dot will be reflected in the C dot. Typically, it will have a number and then a +1, a +2, or a -1 or -2, and that indicates that at the boundary between where the exon and the intron is, there's some spelling change which interferes with the body's ability to recognize that difference between the exon and intron. And again, this renders a non-functional protein. And then lastly, we have deletions or duplications of the SCN2A gene. So rather than a change in the spelling of the gene, it could be that the entire copy of the gene is entirely deleted or duplicated, meaning there's an extra copy. And this typically is larger than just a single gene. It may include other genes that have other functions in the body. And so the presentations for individuals who have this can be different and include other types of medical symptoms than beyond what we typically see with just SCN2A. So again, why is this important? It's important because these different types of genetic changes can lead to different effects on the SCN2A protein. And this affects the way that we think about symptoms to expect and potential treatments and therapies. So when we talk about loss of function variants, these include most nonsense, frame shift, splice site variants, all those variants which disrupt the process of the protein being made or cut off the protein too early. Those are all typically expected to result in a loss of function. But we also know that some missense variants can also cause a loss of function, which can be sometimes tricky to tell the difference between the missense variants that can cause loss and gain of function. And whole gene deletions as well are expected to cause a loss of function. Even though there are different types of genetic changes that can underlie loss of function, we typically expect the overall effect to be relatively similar. Whereas with gain of function, because there are lots of different ways that a channel can cause gain of function, there are lots of different things that can happen, and overall effects can vary widely between gain of function variants. So I wanted to talk a little bit about the information that goes into making a genetic diagnosis when an individual is undergoing genetic testing. So you can understand, how did this genetic testing report come to be? How do they actually know that this change is the cause of anything? And that has to do with a set of standardized guidelines that were put forth by the American College of Medical Genetics back in 2015 that allows for the classification of variants into 5 different categories: pathogenic, likely pathogenic, uncertain, likely benign, and benign. So a variant is found by a lab. It starts out in the middle of this spectrum, and the variant needs to prove itself pathogenic or benign, or it may remain in this uncertain category if there's limited information. So what types of evidence go into actually making this distinction and actually being able to say whether a variant is pathogenic or not? We can look at things like population frequency. Is this change found commonly in the general population, which is really not the case for most SCN2A changes that are harmful? If we look at computer modeling of a variant and the predicted effects, does this prediction show that this variant may be deleterious? If we do functional studies, is there an effect? And if so, what is that effect? Does the phenotype of that individual or the symptoms that they have align well with what we know about this gene? If there are multiple affected people in the family, is this change found in everyone who has the same symptoms? And has the variant been seen before in other people in the medical literature? These are all things that are weighed when making these decisions. So when we say pathogenic variant, it means that the lab has looked at multiple lines of evidence, and there is a lot of strong evidence that says this variant is the cause. Whereas likely pathogenic, we still consider likely pathogenic to be a diagnosis, but this is one where there's slightly less information or slightly less evidence. And then lastly, variants of uncertain significance just means there's limited information overall as to the pathogenicity of this variant. And so if your child has a variant of uncertain significance, discussions with your healthcare provider are crucial to talk about the likelihood that this change may or may not be playing a role in your child's condition. So in summary, these genetic testing reports, they describe the genetic variant, they list the evidence for and against, and they provide an overall classification of pathogenic, likely pathogenic, or uncertain. But some of the pitfalls is that parental testing is usually the strongest factor. So if a change is new in a child, this is typically strongly weighted evidence towards pathogenicity. But if parents are not available for whatever reason, this can sometimes make it hard to make a variant go from uncertain to likely pathogenic. Some older reports have unusual formats. So especially prior to 2015 with those standardized guidelines, there can be non-standard terminology that can be used that can make it hard to utilize that genetic testing report. And then of course, there's static information. We're learning a lot about different SCN2A variants through a lot of the researchers in the room today, but none of this is going to be reflected on your genetic testing report. So this is why it's important to stay in contact with your geneticist or genetic counselor, neurologist, whoever ordered your testing, and periodically talk to them if there are any updates. So in summary, there are lots of different types of changes or genetic variants in SCN2A, and this is one of the reasons underlying why there are so many symptoms that can be seen. So it's important to know your C dot and P dot. If you have a variant of uncertain significance, this is always interpreted in the context with your healthcare provider team. Thank you.